and we can move to the next session because we are 25 minutes late first time. And the chairperson for the next session is Dr. Vivek Raj, Dr. Gaurav Muktesh, and Dr. Ajay Jain. And I think the one of the best speaker is Dr. Taka Itoi. Good morning, Dr. Tako Itoi.
Okay, here's a good afternoon.
Good afternoon.
Good afternoon. So you are going to give a lecture, and just after that, you have a debate with Dr. G.V. Rao, who is a surgeon, pancreatobiliary surgeon. And so after your talk, you will speak your debate topic also, and that after that, Dr. G.V. Rao will come. So I will request chairperson to start the proceeding and invite Dr. Taka Itoi. And next debate also, it should start with Dr. Taka Itoi, please.
Right. Good afternoon, Dr. Takatoi. It's a pleasure to have you, and we look forward to this very interesting debate. And G.V. Rao is a very strong debater and a strong surgeon. So I think we will have a very interesting debate. So we look forward to your presentation first.
Vivek, before you proceed,
yeah,
the pronunciation is Takao Itoi.
Okay, I'm sorry. I apologize. Takao Itoi. Sorry.
Thank you.
We look forward to your presentation, sir. And I think I look forward to the debate even more so.
Okay. Hello, everyone. So I'm Takao Itoi in Tokyo. First of all, I'd like to express my sincere gratitude to all organizing committee, especially Professor Rajesh Puri. And time is limited, so almost 30 minutes behind. Okay, let's get started. Please, video. In this lecture, I'd like to talk on the US-guided gallbladder drainage. Based on the Tokyo guideline, which describes the treatment of acute cholecystitis, early or emergent surgical cholecystectomy is suitable for the treatment of mild or moderate grade acute cholecystitis. However, in case of severe grade cholecystitis or part of moderate grade cholecystitis, gallbladder drainage is one of options. In the guideline, US-guided gallbladder drainage was introduced as a special technique. As you know, there are traditional multiple steps in the USGBD. Of this technique, I'd like to focus on the two important points during the procedure, namely access route and stent selection. So, which one is better? Transgastric or transduodenal approach? I'd like to explain the situation using schema. This is the stomach. Swollen gallbladder of acute cholecystitis is located like this. If the puncture is transgastrically conducted, the needle is advanced into the body or fundus of the gallbladder. In contrast, the puncture is transduodenally conducted, the needle is advanced into the neck of the gallbladder, which has a narrow space. Here you can see the advantage or the disadvantage on the puncture side. Transgastric access is easy. Interestingly, although current indication of ESGBD is mainly the patient with non-candidate surgery, in selected patients of cholecystectomy following USGBD, several surgeons mentioned laparoscopic cholecystectomy is relatively easier in patients with transgastric approach than with transduodenal approach. However, gastric wall is thick and mobile, leading to difficult puncture and tract dilation. Moreover, several investigators large poor metal stent in the stomach may cause the recurrent cholecystitis due to hood reflux. In contrast, transduodenal puncture is easier because duodenal wall is thin, that gastric wall and less mobile duodenum is suitable for stent placement in the aspect of stent migration or dislocation and food reflux. However, puncture site neck of gallbladder is not so large, suggesting that the stent deployment and additional intervention may not be easy. One authority in this field, Anthony Teo, professor, who is surgeon as well as endoscopist, concludes that both technical and clinical success and adverse events rates are similar. In my personal opinion, either access route is acceptable for me, and it depends on the patient anatomy or situation. However, if we want to perform USGBD, I'd like to advise you one thing on the access route. You should avoid the puncture around surrounding area of the pylorus ring about in 2 cm. There are 3 reasons. First, pylorus sphincter is there, leading to longer and harder needle tract. Double puncture of pylorus sphincters or triple puncture of pylorus sphincters and duodenal walls may happen. Second, because of the edge of stent open like pylorus rings or bigger than pylorus ring, hood reflux is often seen. Third, large flange-like lumps causes the obstruction of pylorus ring, like this. So next issue is stent selection. Nowadays, there are 3 types stent for USGBD, namely a double pigtail plastic stent, tubular metal stent, and a room-absorbing metal stent. I love the lamps. It is not commercially available apart of the world, and the issue is reimbursement for USGBD. Actually, lamps does not yet have indication of acute cholecystitis in Japan, although I've published the first USGBD paper using lamps in 2012. Anyway, I'd like to show the video on USGBD using double pigtail stent. The patient with pancreatic cancer has stent-related acute cholecystitis due to metal stent placement. So I conducted transgastrically USGBD using a 19-gauge needle puncture and guide wire placement, and after tract dilation using 300 dilator at this moment. And finally, double pigtail stent was placed. This case was more than 1 decade back. Very nicely placement and the concentrated path came out. Regarding metal stent for USGBD, there are various types stents. Conventional tubular covered SEMS, anti-migration tubular covered SEMS, and the room-absorbing metal stent. As I mentioned, regarding metal stent, I love lamps. Moreover, recent cautery-enhanced lamps delivery system, so-called hot lamps, makes it possible to easily conduct USGBD without serious adverse events. USGBD technique using hot lamps divided into 2 types: conventional over-the-wire technique and freehand technique without needle puncture and guide wire placement. You can see the over-the-wire technique. The puncture was conducted using a 90-gauge needle and guide wire placement, looping, and then hot axios, hot lamps, was advanced into the gallbladder using cautery enhanced. And you can see a very nicely distal flange opening and proximal flange opened. Just 2 minutes from the beginning. Next, freehand technique. And you can see a enlarged gallbladder, including a match pass and a huge stone. At this moment, we selected freehand technique. Directly, quarter-enhanced tip of LAMS advance into the gallbladder, and you can see fluoroscopically. Usually, we can use endosonography and then endoscopy. You can see very nicely flowing of the match pass from the gallbladder. So, question is, which is better, freehand or over the wire? Basically, I love freehand. However, if we worried about the misdeployment in case of duodenal approach at the neck of the gallbladder, that means a small space, you might choose another modified technique. Namely, modified freehand technique in which the guide wire is preloaded up to the tip of the delivery system from the beginning, and once the tip of hot delivery system gets into the gallbladder, guide wire is advanced and coiled in the gallbladder. Of course, if we want to remove the stent because of the benign disease, even large flange lamps, 20 millimeter diameter lamps, more bigger flange is easily removed through the scope channel using biopsy forceps or snare forceps. You can see the video using snare forceps. Stent was removed once in the stomach. The stent get shrink. The braided self-expandable metal stent can easily become shrink. And firstly, we press a plastic stent, double pigtail plastic stent, to keep the root, to avoid the recurrence of cholecystitis. If necessary, multiple. And then finally, we remove the hot lamps using snare forceps. You can see a fluoroscopic imaging through the scope, easily removed. Ladies and gentlemen, in my conclusion, EOS DVD is ready for prime time. I hope this lecture will help you who are a patient. Thank you so much. Thank you. Thank you very much.
Thank you very much, sir. And I think we'll take one or two questions right now, Rajesh. Is that okay, or should we do it after the debate?
So we can do the debate and then we can take questions together.
Okay, all right. So let's do that. So I would like to invite then Dr. J.V. Rao, and we'll initiate the debate process. And thank you for a wonderful presentation for gallbladder.
Professor Vivek, I think it was Dr.
Hello?
Mute.
I think Vivek, Itoi is supposed to do the GJ, EOS GJ first, the presentation, and then
the debate. Okay, yeah, I think it was not clear there. So. Right. All right, so. Sorry, Itoi, please go ahead with the GJ presentation then.
Oh, GJ presentation. I have, okay. Can you see?
Yes, we can. I think you can just put it on a big screen. Yeah.
Okay, great. Quickly. So I show our procedure. There are several treatments for gastric outlet obstruction, and focus on the surgical gastroenterostomy versus US-guided gastroenterostomy. And there are several advantages or disadvantages for US-guided gastroenterostomy. Very nice for the simultaneous double bypass, bile duct and gastroenterostomy at the same time, same procedure, in about 30 or 40 minutes. And just a constant sedation. We can do this endoscopic room. However, of course, less painful. However, the very limited anastomotic site, for example, the surrounding area of the ligaments of thorax, we cannot do this. And of course, possible stent migration of the dislocation and the occlusion, finally. And the most important thing, critical thing is not yet established technique and the limited size of the anastomosis, just up to 20 millimeter so far. In contrast, after this, Dr. Lau will say something the disadvantage and the advantage. I think like this slide, in this slide. So there are several papers between the USGE and the surgical GE. Maybe we sometimes we use the surgical GE. We ask the surgeon to do this, and in such patient, maybe I think we expected a longer prognosis, like 1 year or even 2
Slides
years.
are not moving.
Yeah,
Takao,
yeah.
your slides are not moving.
Really?
We're still on the first slide on the screen.
Oh, really? You can see it, right?
Yeah, we can see
Yeah,
on
now
the
it moves. Yeah.
Oh, okay, okay. Let's see. Okay. Yeah. Okay, you can see.
Right. Right.
So previously I said something, the advantage and disadvantage. And several the investigator reported each procedure, the outcome. And I think I prefer basically the surgical GE gastroenterostomy and the duodenal stent previously, 10 years back, until 10 years back. And interestingly, if in case of a long anticipated long prognosis, we so far we asked the surgeon, the surgical GE. And interestingly, another paper, 2 months prognosis or less and more, we can choose surgical or enteral stenting. Anyway, so nowadays we expected the long prognosis, as I mentioned, 1 year or 2 year. We firstly directly recommend the surgical GE, but in case of 1 year, at this moment, basically we love US guided gastroenterostomy. In 2 months or a lot of ascites or the critical or end stage patient, we use duodenal stent. And you know the very nicely outcome from the high volume center, from only high volume center. So let's see our procedure very shortly. Maybe previous video, I looked at a new balloon, small balloon, but it's so nice, so interesting. Our balloon is completely occluded to occluded jejunum using a big balloon. And after complete obstruction, using water and hot lamps, it takes 15 minutes now. From the beginning to finishing our procedure. Okay, so I think the US guided gastroenterostomy is theoretically very nice, looks very nice, and gravitatically also very nice. And so I think I suggest it is one of option of the gastric outlet obstruction. Of course, some people still not so high evidence level, But some paper similar outcome of the surgical GE or LAP GE, and even interstenting less the intervention rate. So interestingly, this is a final case in patient with acute pancreatitis. In this patient, we do the gastroenterostomy by EUS, and interestingly, after 6 years later, still the opened anastomotic site. Of course, at the time of 4 years, the membrane of the stent broken, broken, but the ingress happened. However, after 6 years, this year 7 years, no complete obstruction. I think this is very helpful, and I guess one of useful was one option. That's it. Thank you so much.
Thank you, Dr. Rao. I think the next to answer your question whether surgery is better than the endoscopic ultrasound, it's Dr. G.V. Rao.
I hope my slides are clear.
Yes.
Now, thank you so much. At the outset, let me thank the organizing committee. Now, the entire crux of this debate is, why is this debate? Is basically because surgical gastrojejunostomy is the global gold standard as in today. There is no doubt about this, and that is the reason why you're trying to have a debate to show that endoscopic ultrasound GJ is equivalent or superior to surgical gastrojejunostomy. This, I feel, is an unfair debate because you're having a no voice or an absolutely no voice general surgical resident who can do this gastrojejunostomy very, very straightforward with a super tech subspecialist endoscopic ultrasoundologist. I mean, this is very, very clear. I mean, a general surgical resident in any college can do this gastrojejunostomy versus a super specialist endosonologist. Now, there are several issues in this actually, and we need to understand the science behind doing a gastrojejunostomy. The site, the size, the shape, the sequence, the sequelae, the stent, the success, and the studies. We call them as 6 S's or 7 S's that we talked about. And from the undergraduate studies, actually, we have been very clearly told that the gastrojejunostomy is a posterior, vertical, retrocolic, isoperistaltic, no tension gastrojejunostomy. It is a standard of practice. And we add a jejunostomy in case you have a long loop. And I think all the students are very familiar with famous mnemonic called as PV ring, which they bug it up to tell them what is the type of gastrojejunostomy that you're supposed to do in a patient with gastric outlet obstruction. And we have to understand that the gastrojejunostomy depends on the anatomy of the transverse mesocolon, the anatomy of the ligament of Treitz, and the left duodenomesocolic fold. All these play an important role to see what type of gastrojejunostomy that you do. It is not just putting in a stent between the stomach and the loop, whichever loop is accessible. Now, this is how a laparoscopic gastrojejunostomy is done. You open up the lesser sac here, and that is the posterior wall of the stomach there. And then that's the transverse mesocolon. I'm making a rent in the transverse mesocolon here. And the jejunal loop is pulled up. You go up to the ligament of Treitz, identify the DJ junction. And then once you're sure about this jejunal loop, you get this approximated to the posterior wall of the stomach. You can see this is the posterior wall of the stomach. This is the jejunal loop here. And then you make an enterotomy on the gastrotomy and the jejunotomy here. And then we use this tape, measure this, and then use this stapler, which is 6 centimeters. You can see this is the 6 centimeter staplers, which creates a gastrojejunostomy. I hope I'm very clear. So it's a posterior gastrojejunostomy, which is a linear gastrojejunostomy, which is about 6 centimeters wide. Now, there is no tension. The anastomy is about 6 centimeters, absolutely hemostatic. And the stapler type depends on the tissue thickness that we use. It's not lumen opposing, it is basically anastomosing. And you can also do a hand-tuned anastomosis, which is equally efficacious, and it's also cheaper compared to the laparoscopic stapled anastomosis. And we have a lot of data which come up to show that these laparoscopic gastrojejunostomy has got lower intervention rate and is an established surgical procedure, less non-invasive than open GJ, and it has got good long-term results. compared to EUS-GJ, which requires a special device, special equipment, and it's a non-established endoscopic procedure with serious adverse effects. And it is not just gastrojejunostomy. Sometimes you have to do a partitioning gastrojejunostomy that is called as, and sometimes you have to do a Roux-en-Y gastrojejunostomy to prevent severe bile reflux into the thing, which is one of the commonest causes of morbidity in these patients who undergo gastrojejunostomy. In benign peptic ulcer disease, actually, you do a vagotomy in addition to gastrojejunostomy. It is just not simple gastrojejunostomy. You have to identify both the truncal, this is the posterior truncal vagot trunk and the anterior trunk, both need to be identified, cut, and then you have to send this for biopsy to show that you have cut the vagal trunk, then do a gastrojejunostomy. So for a benign gastric outlet obstruction, which is a consequence of peptic ulcer disease, it is not simple gastrojejunostomy, but we have to do a total truncal vagotomy in addition to a drainage procedure. And for perforated peptic ulcer, it is known that laparoscopy is the gold standard right now. And for all unstable patients, we can do an open procedure, but for all stable patients, we can do a laparoscopic procedure. Now, this same question, now I present to the endosonologist, which is the preferred GJ for gastric outlet obstruction. Sorry, they talk about EUS-GJ, 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 and EUS-GJ. For everything, there's only one solution, please. Just put in a stent between the stomach and whichever loop is accessible. Absolutely, this is a no-no situation. Now, see, when you do an endoscopic ultrasound, you should understand when you're distending the stomach, is this a true GJ? Is the nomenclature correct? It is just a fistula that you're creating. You have to understand actually the sagittal sections, you take the thing and then you see whether the loop is accessible or not. Actually, I personally feel you have to get a good sagittal section cross-sectional imaging before you can do this. And you make sure that, see, whenever we distend the stomach, the jejunal loop goes away from the thing. The duodenum comes closer, the stomach comes closer to the duodenum, which is a fixed structure, and the jejunal loop goes away. Even if you put that balloon away, what you're getting is the ligament of Treitz, the DJ area that comes closer to the stomach. So this is what happens. This is the virtual thing that is done when you're putting a thing. Can you see this? The jejunal loops away from the thing. So it is just a duodenotomy or just a fistula that you create between the stomach and duodenum. And if you see, this is the endoscopic gastrojejunostomy video that I borrowed. It is you're using lumen opposing stent and not lumen anastomosing stent. It's a fistula that is created which stretches up to about 2 centimeters. There is a tension approximation because it's a mobile stomach and the mobile bowel, and it is not a hemostatic, and it is shown that some hemorrhagic complications following this. And you can see this, whenever we do this gastrojejunostomy, this shrinks. You put a 2 centimeter, it shrinks to about 1 centimeter, whereas this surgical GJ is about 6 centimeters in diameter. Now, endoscopic gastrojejunostomy, also they feel that bigger is better, but they cannot achieve bigger, basically because that's the limitation on the stent size. This smaller anastomosis we do not for gastric outlet. This is done for bariatric procedures. You're doing a circular GJ that is comparable to the bariatric surgical gastrojejunostomy that is done, wherein we want to limit the efflux of gastric contents. And it is shown to be inferior to the linear gastrojejunostomy that is conventionally performed. Does size really matter? Yes, of course, the linear gastrojejunostomy is superior to circular gastrojejunostomy. And there is a lot of data to show that actually whatever data you're showing from your endoscopy side, a lot of things comparing open surgery, which is not fair in the current data, and most of them are supported by industry. And we have this recent paper which came in 4 retrospective studies and 1 prospective study. Actually, you can see this. There's still limited data and sparse literature, numerous studies reporting redundant patient information. We don't have complete patient information and absolutely conflict of interest. All of them have some association with support with the industry. And all these publications, whatever you have, if you read the last paragraph of this, they are supported by the industry. And you can see that this is a huge data which shows that is associated with complications, and the complications seem to be happening more than what is reported. Absolutely, very, very clear. And this is the panel discussion that happened just the day before, and they told us that there are 20% complications. This is a panel which included everybody from India. And they told us that 20% incidence of complications following these advanced J procedures. And it is not the time. Procedure is technically demanding. It should be performed in highly trained endosonographers with experts in interventional EUS. There's refinement required. And then there is a chance of misdeployment and stent migration. And again, Sandeep, if you've seen the live demonstration the other day, they have shown the limitations, they have shown the expertise is required, and they also confirmed that it can be done only by a few endocrinologists, not by all endocrinologists. And for malignant gastric outlet obstruction, which is the best option, this is a very clear, and they have all the big endocrinologists who wrote this article, which says that such procedure is not standardized, and prospective comparative studies need to be done to define the best strategy for these patients. For benign peptic ulcer, EOSGJ no role, because you all require a vagotomy, and these patients will require continuous PPI, otherwise they'll end up with stromal ulceration. Cost-wise, literature shares that laparoscopic GJ is costlier, but again, the panel discussion that we had on 15th of this month in this state showed, Dr. Reddy showed the data very clearly that it is a very, very expensive procedure and compared to the surgical procedure. And we need larger prospective studies, RCTs and meta-analysis before we can show that this is superior. So if you compare in evidence-based surgery, surgical GJ, gold standard, EOSGJ, just individual case reports, case series and some studies, and we don't have data to show that it can be done. And they depend on all other types of evidence other than evidence-based surgery. You talk about eminence, vehemence, eloquence, providence, diffidence, nervousness, confidence. You talk about all this evidence can be done, is not, should be done. And so to conclude, is the nomenclature correct? Absolutely no. Site is variable in endoscopy, size maximum 2 centimeters, shape circular comparable to bariatric GJ. Complications are more, additional procedures not possible, benign gastric outlet obstruction not recommended, cost expensive, can everybody do it? No. What is the strength of impact? Low. Does evidence support? No. Now, so EOSGJ anatomically, physiologically, pathologically, economically, scientifically is an absolute no-no compared to surgical gastrojejunostomy. I hope I've convinced you people that it can be done in select few patients, and as Itoyo said, yes, it can be done, it is feasible. Select few patients, it can be done, but it can be done with select few people. Thank you so much for the patience.
Can we get off the slides, Dr. Rao? Hi, Dr. Itoyo, you are on screen now. So,
yeah. So, starting the debate.
yes. So,
Okay.
your comments.
So, first of all, thank you very much, Professor Lau, for very nice presentation. I partially agree with surgeon. Surgical GJ is gold standard because so in our unit, in our department, in our hospital, surgeon always said like you, EOSGE GJ is a gold standard, and in particular, laparoscopic surgical GJ is a gold standard. So my question is, you mean the gold standard is open or laparoscopic GJ? Which one?
Yeah, it's a very good question. Actually, if you have to compare head to head, it has to be EOSGJ with laparoscopy. I personally feel laparoscopic GJ is the gold standard as in today. It can be done very safely. It is a standard of practice in majority of the centers. Even open GJ is not that very complicated. Actually, it requires a small mini laparotomy to do this staple gastrojejunostomy.
Yeah. So if so, we want to surgical GJ. We mean endoscopist means laparoscopic GJ.
Yeah.
At that time, I think not always all surgeon can do this. So it is similar to EOSGJ. So some expert of laparoscopic procedure, a surgeon can do laparoscopic GJ. For example, in our unit, not always all surgeon can do this. So what do you think about this?
I mean, I cannot comment on what happens in Japan, but I think if you ask any of the panelists sitting here, actually, the gastrojejunostomy is the first procedure that is taught to all the residents, even for the surgical residents. Actually, is the first procedure after appendectomy that is taught to all these people, and everybody can do this procedure. Actually, I personally feel, it is not a complicated procedure.
Yeah, I know.
Does it. Yeah.
I know. I mean, all of Indian surgeons can do laparoscopic procedure. I mean,
Yes, I think now it's the current this thing actually.
Really?
Especially this gastrojejunectomy, a stapled gastrojejunectomy is a simple, straightforward procedure.
Okay, so if so, I agree with you. Yeah.
Thank you so much.
Laparoscopic GJ is a very safe and very less minimum invasive treatment.
Yeah, absolutely.
For example, another question, in patient with a critical ill patient, at that time, for example, the expected prognosis less than 2 months, or very much ascites, or
Okay.
at that time.
Okay, this is a very good question. I am also an endoscopist. Actually, I practice endoscopy. Suppose if you're asking me if the patient is critically ill, then I think you're talking about the functional status of the patient whose albumin levels could be very low. In these things, actually, I would rather suggest this patient undergo an enteral stent rather than for a surgical gastrojejunectomy. Because, the endoscopists also argued with the surgeon that enteral stent was better than a GJ before. Now that the GJ has come, as arguing a GJ versus a GJ. So if the patient is absolutely sick with low albumin levels, functional status is not very good, because again, EOS GJ has to be done under general anesthesia, please. Whereas the enteral stent can be placed with the maybe IV sedation. I think I would opt for an enteral stent rather than an EOS GJ.
Okay.
I think we have some questions from the audience and from the panelists for both the surgeons and the endosonographers.
We've had two experts and stalwarts in the field talk about their respective areas. So I think any comments?
So I had a question for both actually. So, I'm an endosonographer, but I do not do this fancy maneuvers yet. The question is, are we in the evolving phase right now? And maybe just like what happened with pseudosis gastrostomies and with, walled-off pancreatic necrosis, 10 years ago, we were not talking about it being standard procedure, but slowly it became standard procedure. Are we likely to see similar evolution? Because we are at a very early stage of endosonographic gastrojejunectomy.
Exactly. So, many years ago, around the 1990, laparoscopic cholecystectomy is very heritable in Japan. But nowadays, gold standard. I think if the technique is established, maybe I guess USGJ is a more safe and more reliable procedure for treatment of gastric outlet obstruction. But so far until now, I don't think it is very nice or complete procedure.
Yeah, I agree with Professor Itoi on all the panelists. Actually, it's an evolving procedure. Yes, it has its limitation right now. We know that actually it is getting refined actually, but as you rightly said, actually a select few patients can be taken up for this, but it should not be generalized that all patients with benign gastric outlet obstruction and malignant obstruction should be subjected to EOS GJ, because one, expertise is very, very limited, the costs are prohibitive, and still we stabilize the thing. Maybe a decade from now it could become the gold standard, but as in today, I think we're still evolving, and I think we should respect the surgical this thing as in today, I think, and at the same time, parallelly, we allow the endoscopic ultrasound procedures to evolve so that we'll have it's a win-win situation for the patient at the end of the day.
I think I largely agree with Dr. G.V. Rao, sir. What we have noted is at our setup, we often put enteral stents, and then we realize that the enteral stent gets occluded, especially in malignant cases, sir. So these are the special subset of patients that we eventually go on to take for US-guided gastrojejunectomy, so as to avoid another surgery. So what is your take on this subset of patients, sir, who are actually having an enteral stent that gets blocked? The reason being because it is passing through actually a malignant obstructed lesion, just like what we see in US-guided biliary drainage procedures. We're trying to bypass the obstruction. So what is your take on these subset of patients, sir?
Very good question. I'll ask the same question. Why did you put the enteral stent first? Because 6 months before, the endocrinologists or the endoscopists used to argue with surgeons that the enteral stent is better than the surgical gastrojejunostomy. Now you yourself are saying that the enteral stent is inferior to the so please, see what I'm saying is, as Itoi has said, if the life expectancy is very short, any of these procedures, I mean, Itoi is very clear. Actually, I respect what Professor Itoi has said. If the life expectancy is short, yes, we can do all this. But if the life expectancy is more, I think we should do a proper gastrojejunostomy as a palliative procedure. But I would still do even an open gastrojejunostomy. See, it would just require you don't understand, these people are emaciated, very thin. All it requires is a small incision, pull up the stomach and do a staple gastrojejunostomy.
So sometimes we cannot expect the patient prognosis, right? Sometimes very nice efficacy of chemo or radiation. In such cases, as the Mukesh mentioned about the after occlusion of the duodenal stent, I think one of potential is USGJ. Actually, 20% of in our case, like this, the occlusion of the duodenal stent, and we did USGJ. Patients maybe not so long procedure. That's why. So instead of surgical conversion, but not surgical conversion, but USGJ. Actually, after that, the prognosis is not so long.
The other thing that I say is actually it is a procedure that has to be done by everybody. See, we cannot just do a gastrojejunostomy to about 4 centers across India. You see the number of patients who require gastrojejunostomy in the country, and if we just have to send these patients, all these patients for gastrojejunostomy to the select 4 centers, it's impossible. So it has to be a procedure that can be done by everybody. Ultimately, that is what is the procedure becomes a gold standard.
I would like to thank all the participants and speakers for this lively debate. But for the lack of time, I think we need to move on to our next session. And I thank Dr. G.V. Rao, Dr. Itoi for a wonderful debate, and our dear chairpersons, Dr. Vivek, Dr. Gaurav, Dr. Ajay Jain. And thank you very much, sir.
Thank you very much.
Wonderful debate and wonderful presentation. Thank you, Dr. Itoi, for joining us from class.
Yeah, thank you, Vivek.
And
Thank you so much. Thank you so much.
Yeah, thanks so much.